Good afternoon, everyone. I've got 1:57 p.m., so we'll give it just a few more minutes and continue to let folks in, and then we'll get started. Got just a couple of minutes and we'll get the webinar started for this afternoon. All right, I've got 2 o'clock on the dot, and I know we've got lots of information to cover, so I'm going to go ahead and get started this afternoon. Just wanted to welcome everyone. Good afternoon. Thanks so much for joining us this afternoon. This is our July Georgia Perinatal Quality Collaborative Maternal webinar, and it's titled Quality Tools and Strategies for Postpartum Care Optimization. Before we get started, just a few housekeeping items. Please make sure to mute your lines during the webinar to avoid any interruptions. This webinar and past webinars are housed on the Georgia PQC website for review at your convenience. They're located under the Maternal tab. We should have a few minutes for questions at the end of the presentation. Feel free to type any questions into the chat. If for some reason we run out of time and you have a question, feel free to email us and we will get back to you. We wanted to share the lineup of webinars and speakers through this year. We look forward to your participation in these webinars. Feel free to share the flyers and the links with your colleagues and partners. Many of you during this year have experienced staff changes, and if you've received the information for this webinar from a friend or colleague and would like to be added to our listserv, please email me at amy.mock@dph.ga.gov, and I'll be happy to add you to that listserv. Just a few maternal updates to share today. You should have received the biannual Georgia PQC survey at the end of last week. We ask that you complete the survey by close of business Monday, July the 15th. This survey, of course, gives us insight into the work you're doing and how we can best support that work. Information from the survey will be compiled and shared in aggregate form at a later date. The link is on our screen for the survey. And again, I'll be sending that out as a follow-up email next week for those that may have missed that in their email box or just have not had time to get to it. Our next Georgia Maternal webinar is scheduled for Tuesday, August the 6th at 2 p.m. The guest speaker for that is Dr. Catherine Lindley. She'll talk about pregnancy, cardiac conditions, and bedside care. CMS has launched a maternal health webinar summer series with a focus on maternal and infant health. They'll be hosting a webinar on July the 16th titled Addressing Hypertension Before, During, and After Pregnancy, and the link to register is on the slide there. The next Maternal Health Echo is scheduled for August the 25th and will feature Dr. Monique Bethel and Tasha Charles from Wellstar MCG Health. It's titled Cardiac OB, Addressing Cardiac Health for Women in the CSRA. Quick reminder that Q2 data for April through June has a due date of July the 31st, but we will be extending the submission date back to August the 9th due to our transition to Simple QI. The plan is to have Q2 data entered into Simple QI. With that being said, we've been talking about Simple QI for the last several months, and we're excited to be working with Michael and his team. We anticipate training with our pilot sites to begin the week of July the 15th. The plan is to have Simple QI ready for you all to submit that Q2 data by August, and we've got more to come related to training and transitioning, so be on the lookout for that and make sure that your data leads are aware that that's coming. If you do have any data-related questions, please do not hesitate to contact someone at GAP QC for assistance. We're happy to help. We currently have 16 actively participating hospitals located within 5 of the 6 perinatal regions. We're still in active recruitment for Wave 2 of the Cardiac Initiative and would love to have you and your facility join us in this work. If you're interested in joining as part of the Wave 2 recruitment, please reach out to get signed up. We also have the QR code on the screen here with the enrollment form, and you can utilize that to enroll as well. Many of you heard from and spoken to Jennifer Boland. Jennifer's the Women's Health Improvement Advisor, and she's been reaching out to provide TA and coaching calls. She has a wealth of experience and expertise regarding maternal bundle implementation across all levels of care. And Jennifer would love the opportunity to connect with you and your team. So please reach out to Jennifer or be on the lookout for her to reach out to you. She's available for any support needs that you guys have. Just a quick look at the key driver diagram for maternal cardiac conditions, which show the goal to reduce severe morbidity and mortality related to maternal cardiac conditions in Georgia. And just a reminder that our SMART aim is to reduce harm related to existing and pregnancy-related cardiac conditions through the 4th trimester by 20%, with a date of having that done by February the 6th of 2026. And then you can see that the process and structure measures are embedded into the interventions there. So we always like to share that with everybody as a reminder of why we're doing this work. Many of the resources and opportunities we're about to share with you can be used to meet the process and structure measures outlined by AIM in the Cardiac Patient Safety Bundle. One such opportunity is sponsored by Hope for Georgia Moms, North Georgia Health System Center for Simulation and Innovation, and A1. They've teamed up to provide obstetric patient safety training. They have multiple dates scheduled, with the next one being scheduled for July the 25th. This is an opportunity to enhance skills in managing OB emergencies through simulation and debriefing. The training aims to equip clinicians with the knowledge and techniques to effectively identify, assess, and manage patients in critical situations. So if you or someone from your facility would benefit from this training, please reach out to Tasha, and Tasha's email is there on the screen for you. Just a quick reminder that our educational materials are available on our website. You can also use the QR screener or the email address on the screen there. You can print those, you can co-brand those with your facility logo, or you can reach out to Standard Press, Steve McCart, and he can order those for you, drop ship them directly to your facility. We have now available Spanish versions of these as well. So please utilize those in your education. A new opportunity that we want to share with you is the American Heart Association now has learning modules that are available online. With their permission, we're happy to share 2 of those modules available at no cost that align nicely with the work we're doing around cardiac. The first one is the role of maternal health in cardiovascular health, and the second one is addressing health disparities. You can use the QR codes on the slides to access the learning modules. The modules are interdisciplinary. They're created by experts, guided by the overarching goal to improve women's cardiovascular health and eliminate health disparities, identify and explain the increased cardiovascular risk and contributing comorbidities that affect pregnant and recently pregnant individuals. These modules do come with CME CE credits, and this could be an option for meeting your process measure 3, 4, and 5 in some of your facilities. We continue to share that AIM has updated their patient safety bundle learning modules. And of course, each of these courses features a comprehensive overview of the AIM patient safety bundle and its key elements. The modules are a great way to get your clinicians, providers, and staff educated on hemorrhage, hypertension, and cardiac conditions in OB care as a way to meet process measures 3 and 5 related to training and education. Reminder that if your hospital utilizes HealthStream Learning Management System, you can find the modules there and earn CME and CE credits through that platform. If your facility does not utilize HealthStream, you can access NurseGrid Learn through July the 31st and receive CME CE credit for the AIM Patient Safety Bundle learning modules. So use the links on the screen. In the search bar, type in AIM, and then Patient Safety Bundles will appear for you to select. So now, without further delay, I'd like to introduce our guest speaker for today's maternal lecture series. Please help me give a warm welcome to Dr. Jamie Morgan. Dr. Morgan is an associate professor in the Department of Obstetrics and Gynecology at University of Texas Southwestern Medical Center in the Division of Maternal Fetal Medicine. As an academic maternal fetal medicine physician, Dr. Morgan is passionate about providing care for women with complex medical diseases or major obstetrical complications during pregnancy. Her academic and research efforts focus on obstetrical quality and safety, maternal disease states in pregnancy, and optimization of postpartum care. She currently serves as the maternal medical director at UT Southwestern's Clements University Hospital, a level 4 referral center in Dallas, Texas. Regionally, Dr. Morgan leads quality initiatives in her role as deputy medical director for the Texas AIM program, a state initiative funded by the Department of State Health Services aimed at reducing common causes of maternal morbidity and mortality in Texas. In addition to her regional quality leadership, she also participates in national quality and safety efforts as a clinical champion for the Alliance for Innovation on Maternal Health. Dr. Morgan just completed 3 years of membership on the State Maternal Fetal Medicine Patient Safety and Quality Committee, where she also acted as a liaison to the SMFM Health Policy and Advocacy Committee and published multiple peer-reviewed quality publications. She's been named a Texas Monthly Super Doctor Rising Star every year since 2019 and is a member of Alpha Omega Honor Society. Please help me welcome Dr. Jamie Morgan. I'm going to turn it over to you, Dr. Morgan.
All right, sounds great. Thank you for that kind introduction, Amy. I'm sorry it was way too long. Before we get started, if you want to advance to the next slide, I just wanted to give, well, first of a couple of things. Number one, I'm so envious that you all are getting Simple QI. In Texas, we've been using Qualtrics. We tried to get Simple QI, but we couldn't, and I understand it is an amazing platform. So congratulations to you guys, and like I said, I'm definitely jealous. Second, I guess my disclaimer is, and hopefully it's somewhat obvious from the title, I'm not focusing on cardiac conditions specifically. I know that's what you all are working on, but I am hoping that a lot of what we discussed just broadly applies against, when we're talking about maternal care optimization. And a lot of the risk factors that we focus on, of course, are antecedents for some of the cardiovascular disease that we see, particularly in the postpartum period. So I'm hoping you'll still find it relevant to the work that you're doing, although I know it's a little bit tangential because it's not specifically cardiac. Next slide, please. Okay, so basically we'll start off with a very brief introduction on maternal health in the US. I know you all know this, but I hate to not, to leave anyone behind in case you haven't seen this data for any reason. Also, I will briefly do some level setting, talking just about sort of the quality improvement framework, just before we get started on specifically talking about tools and strategies, because I want to make sure that everyone sort of understands where the discussion fits in the overall framework and improvement opportunities that we're working on. And then we'll talk about the immediate postpartum transition period, which is something I think probably since you guys are doing AIM bundles, this is largely a hospital-based group, which of course AIM is. And so really so much of the successful transition really starts at the hospital level before the patient ever leaves the hospital, leaves from their discharge or their delivery hospitalization. So want to talk about what's available from a tool, strategy, optimization standpoint that you might use, especially focus on, again, in the inpatient setting, and then how we talk about enhancing care and coordination in the postpartum period, and particularly looking at some of the innovative tools and approaches that have been used to help, better optimize care and also streamline the patient experience, because I think, there's a lot that our patients have to navigate in the postpartum period. And, particularly if they have a medical condition, it can be sort of overwhelming. So, all right, next slide. All right, so briefly, current state of maternal health, just again, a little bit of level setting. I know you all have probably seen this. I think, though, it's still a nice graphic to look at. And you know that, obviously our national mortality data lags a little bit. But the disturbing trends in maternal mortality and significant disparities are certainly undeniable and only seem to be increasing over time. So we know that non-Hispanic Black women consistently bear the largest mortality burden, which is so starkly evident in this figure. So in 2021, non-Hispanic Black women had the highest rates of maternal mortality at 70 deaths per 100,000 live births. And regardless really of whether even in all, if you're looking across all racial demographics, the number is increasing over time, and we've gone from 17.4 deaths per 100,000 live births in 2018 to 33 in 2021. Next slide. The timing of maternal deaths has also been a really recent focus in the search for improvement targets. So half of pregnancy-related deaths in the US occur between 1 week and 1 year after delivery. And about 10 to 15% of those occur between 43 and 365 days, which was certainly an area that we were not as focused on previously. The leading causes of death vary a little bit based on when in the pregnancy the death occurs or in the postpartum period. But we know that cardiovascular conditions, mental health conditions, and infection top the list for all pregnancy-related deaths, while hypertensive disorders and stroke contribute more prominently in the postpartum period. Regardless of what we're looking at, we know that many or most of these causes are potentially preventable, which is why they really deserve a lot of focus. And hopefully, again, they're largely what we are, nationally and certainly regionally working on in our improvement efforts. Next slide. So while pregnancy-related deaths continue to climb, delivery-related deaths in hospitals have actually decreased over the past 14 years, most likely as a result of national efforts to improve the quality of care during the birth hospitalization. So the reduction in death has really translated into a rise in maternal morbidity, since these women are dying less frequently and instead suffering morbidity as shown on the bottom graph, which is actually a positive change and what we're aiming for. So, again, taken together, this is really a favorable shift. And again, these quality improvement initiatives and inpatient safety bundle implementation are likely largely responsible. However, since the overall numbers are still trending up, this means that we're seeing more and more maternal deaths occurring outside the hospital, which is clearly where we need to focus our efforts now. Next slide. Because maternal mortality is much less common compared to other negative maternal health outcomes, there is more opportunity to review and generate actionable recommendations for every pregnancy-related death. And the overlap between pregnancy-related deaths and other negative maternal health outcomes indicates that actions taken to address the medical and non-medical contributors to maternal mortality likely have a cascading effect, meaning that our collective work to prevent maternal mortality can improve maternal health outcomes across the spectrum of severity, decreasing deaths and complications and bolstering overall maternal health. Next slide. So this is data from Texas, so I know that's specific to us, but I still think it probably largely applies across, more broadly across the state, across the nation. But this is from our Texas Morbidity Mortality Review Committee, which looked at contributing factors to pregnancy death in the patient and family domain. And what is clear is that many of the contributors really need to, at least on some level, be addressed in an ambulatory space, and start with systematic improvements in both antepartum and postpartum care. If you look at the list there, it's clear that this is not, that the sort of inpatient delivery hospitalization is not adequately going to address a lot of these contributors. And so we really have to look to the ambulatory space to focus our improvement efforts. Next slide. Similarly, mortality contributors in the provider domain touch on processes that span the entire pregnancy and postpartum care period or relate to outpatient specific factors. So again, we really need to make a dent in the trends that we're seeing. We really have to shift our focus from the hospital a little bit, where we've had a lot of success, to that ambulatory space. Next slide. So I'm sure that this group is well aware of how complex and difficult this problem is. And so realistically, the solution is going to have to be equally complex and multi-pronged. There are many stakeholders that need to come to the table to make sustained change. And this really includes this list here shown on the slide. So patients and their family, communities. Obviously, we play roles as healthcare professionals, but we are part of this larger ecosystem. We need birthing facilities, payers, innovators, and researchers. So while we are certainly focused on the healthcare professional aspect of things, we also have to recognize that we are part of a much broader system that needs to change as well. Next slide. So this is from the Surgeon General's call to action to improve maternal health, and it outlines different strategies for stakeholder groups to consider in planning implementation efforts. And for healthcare professionals, the recommendations are listed here, and much of what we're going to talk about and focus on during the rest of this presentation will fall into one of these categories. So hopefully we'll cover a lot of breadth and depth during the course of our conversation today. Next slide. All right, so before we dive in on the specific resources and improvement ideas, I just really want to quickly contextualize our discussion by reviewing general QI model or paradigm. So I know, like I said, many of you are already familiar with this, but this level setting will ensure our discussion today fits into the broader improvement framework. Next slide. So I really like this graphic because it demonstrates the critical steps and contributions to the quality improvement cycle, as well as the potential cycle for our improvement, potential targets for our improvement work. So for the purposes of our discussion today, we'll largely be focusing on the right half of the diagram, related to guidelines, clinical decision support tools, clinical care implementation, and measurement. Next slide. So when gaps in care quality are noted, as is true for the postpartum period, toolkits, bundles, and checklists are an array of quality tools that essentially translate what should happen into tangible change by helping guide what we should be doing and providing the tools to support these best practices. So in just a moment, I'm going to introduce you to some helpful resources, I hope. If you haven't seen them already, some of you may be very familiar with these, and we'll be referencing throughout the talk. So I just wanted to make sure we were all grounded in where these fit in the overall quality improvement cycle. Next slide. And you can just scroll through this, Amy. I'm sorry, I forgot this graphic. It's like got all these little. So an integral part to any change, of course, in the quality domain is measurement and assessment. So honestly, we couldn't do QI work, right? We wouldn't be able to prove that we're improving if we can't measure. So therefore, the creation and awareness of sort of evidence-based quality measures, whether they be structure, process, access, or outcome measures, is absolutely critical in driving QI work. So even though some of what we'll be talking about today aren't necessarily strategies or ideas for innovative implementation, they are still really critical to driving care forward, because they largely frame what we measure, how we measure it, and then again, also often provide an area of focus for payers, for health systems, for individuals, that can be really critical to the quality improvement process. Next slide. And finally, the implementation piece kind of largely consists of optimizing the clinical workflow. So that encompasses most of the cycle shown here, at least in some form or fashion. Obviously, the what piece we just talked about, that was sort of the tools, the toolkits, the bundles, the checklists. But a lot of the other elements that are critical to the life cycle of quality improvement are really about where, the implementation in the clinical workflow and how we can improve that. And we'll be, again, talking about some innovative strategies, particularly related to the postpartum period, that have been tried in other settings and, again, maybe are being tried in Georgia. I'll be interested to hear on the end if that's true. Next slide. So I know, again, you all are very familiar, but this is obviously some of the best known, and honestly, I think hopefully you all would agree, AIM spends an amazing amount of time and effort creating these bundles and ensuring that they are evidence-based and widely applicable. So they are obviously a great place for us to always be hearkening back to and looking for, and certainly we'll be referencing throughout the session today. Next slide. So I also wanted to make sure we're going to talk a lot about some of the Society for Maternal Fetal Medicine checklists and other toolkits. There's a bunch of safety related content that is available to the public. I'm not sure if you all have used this. I think it is a fantastic resource, really, that extends way beyond. Obviously, I know it's been developed by MFMs, but this is really applicable across a much larger spectrum. And you don't have to be a member of SMFM to access these. The website actually looks slightly different since I made this slide, but essentially under the clinical guidance, you can find all of this content. And again, you don't need to be a member of SMFM to access it. So if you haven't seen it before, I'll be talking through some of the resources available there throughout the rest of the presentation and encourage you to take a look at it after. All right, next slide. Okay, so first, I'm going to focus on preparing for the immediate postpartum transition, which again is really that pre-hospital discharge period, which I sometimes think we don't capitalize on enough. I've certainly realized that in my own institution. I imagine that many of you might feel the same. So we're going to talk about some of the best practices and tools that are available to aid in this first part of the transition. Next slide. This is just a slide that I really like, because it is true that if we want to get better in the postpartum care piece of this, we really have to prepare the patients a little bit better than I think we typically have. And if we fail to prepare them, then obviously we are preparing for them to fail. So just kind of recognizing how critical this piece is as we're getting them ready, both for the immediate postpartum transition as well as for their sort of larger well woman care after, when they transition kind of out of the immediate postpartum period. I think we can start to set the stage for that really in the hospital before the patient's even discharged. Next slide. So I want to focus, there's really kind of two transitions if we think about the postpartum transitions of care. There's obviously that immediate transition when the patient is going from having had her delivery to being, going home, and obviously sort of trying to make her way through the postpartum period, which there's a lot that's happening, as many of you I'm sure know from personal experience, as well as what we do on a day-to-day basis. And then there's also that second transition period, which we'll talk a little bit about, which is really from sort of out of the immediate postpartum period to a well woman or a chronic disease management. we sort of hone in on what needs to happen from that first postpartum transition, there's really a lot in there that we need to be addressing and thinking about. So optimizing medical or obstetrical conditions, obviously scheduling timely blood pressure checks and postpartum visits. We need to make sure, I know that focus is not as much equity driven today because I won't have enough time to cover all that. But I'm hoping and I'm sure that you all are really paying a lot of attention to social determinants of health and how, social and structural barriers can really play into a patient's ability to receive optimal care, both during and after her delivery. So assessment of technology and remote monitoring access. So, giving the patient a blood pressure cuff if she doesn't have the ability to check in, she doesn't have a phone, that sort of thing, doesn't help that much. And then again, assessment of childcare and transportation needs. In Texas, we did a really interesting simulation during one of our learning sessions where it really focused on this, not so much the medical aspects, but how hard it is for patients with social, when they have other social and, constraints to navigate the postpartum period, because there's so much they need to do. They need to go to childcare visits, blood pressure, checks, postpartum visits. They need to pick up medication. Again, there's just a lot that they have going on. And if we haven't asked about childcare access and transportation needs, then we are setting up patients to not be able to follow through on the plans that we're helping to make for them. Anticipatory guidance and comprehensive education on postpartum warning signs, and also really starting that conversation about the importance of postpartum as well as long-term care. And we'll focus in a little bit on, particularly sort of the risks related to pregnancy morbidities like severe preeclampsia, and the discussions that need to really, we shouldn't sort of say, well, that will happen later, because I think that we need to really root those discussions starting from the very time that they happen, because we never know what kinds of education the patient might get as she moves forward. And we may have an opportunity as hospital providers to really make sure that she understands the importance of follow-up, starting kind of in the immediate postpartum period and then transitioning to much more sort of lifelong health. Communication between inpatient and ambulatory providers, that's typically, unless even in an integrated health system, which is certainly where I work, but that can still be a challenge. And then establish communication between the patient and their ambulatory provider. So depending, I know there are, for example, some FQHCs where if the patient has a complication, they aren't able to see them in the postpartum period. They may not be able to go back to their same provider. So these are real challenges that we have to start by assessing while the patient's still with us, so that we can make sure that we optimize her discharge care plan and not just send her out the door without the tools to be able to take care of herself and her baby. Next slide. So obviously, traditionally, we've used very objective clinical measures such as morbidity and mortality to assess maternal health during the postpartum period. But honestly, these measures really fail to offer a complete description of the patient's experience post-delivery. And certainly recent data suggests that we may be falling short on this. So this is from some qualitative research that was conducted to explore women's and clinicians' perceptions of the postpartum experience. And basically, a number of themes came to light. So women, number one, they felt that they lacked sufficient knowledge about postpartum health, and they weren't prepared. They lacked continuity of care, and they also lacked that early care during the postpartum period, which I know, again, we'll talk a little bit about the traditional paradigm and where we need to move in terms of how we think about postpartum care, and certainly the importance of that early postpartum follow-up. Sorry, hold on. There is a disconnect between providers and postpartum mothers, and there's a need to bridge the gap with innovative approaches to care. And so these are really important themes that we need to focus on as we're trying to figure out how to plug some of the holes and gaps that we see. Next slide. So this is from, again, just looking at this education gap specifically. This was for women with hypertensive disorders of pregnancy, and it's just to give an idea that, again, even women with elevated risk factors, that only 25% had any documentation of, some counseling related to their prior hypertensive disorder. The very few About a fifth of them were counseled on the need for follow-up with a primary care. Gosh, less than 10% received any counseling on future risk of cardiovascular disease. And then even that opportunity for pre-pregnancy counseling before their next pregnancy wasn't even mentioned. So we really have, again, a lot of gaps in our counseling and education that I think, we hope that if we could start to close these, we might make a dent in some of these statistics. Next slide. So this was from executive summary. It was a cooperative that was convened by SMFM and ICHG and ACOG back in 2017. And they were looking to sort of assess how do we close the postpartum care gap and what quality measures do we need to drive change and improve health. And so I think we're going to talk a couple of times throughout the rest of this discussion about number 4. So they identified that they really needed, or one of the proposed measures that would help to capture some of the missing information and maybe start to close that gap was the proportion of postpartum women with a current diagnosis, a hypertensive disorder of pregnancy diagnosis, who, number 1, have a documented care transition with a primary care provider, and number 2, receive education on future cardiovascular and metabolic complications before hospital discharge. And I'll talk a little bit more about this on the next slide. So we actually just recently decided that we should take that because, again, up to date, there hadn't been any addressing of development of a measure that sort of fit and helped fill the gap that was identified by that prior collaborative. So we have just recently, this is still moving through the approval process, but hopefully will be published soon, split this metric actually into 2 different measures that we're going to propose people start to use and adopt, again, both locally, individually, as well as hopefully eventually maybe on a health system level. Some of these have to be measured on a more local level, whereas some could be maybe measured at the insurance, at collections and all of that using some of the available billing data. So this first one is the education of lifelong risks of hypertensive disorders of pregnancy prior to discharge. So like we talked about, there's a big gap that was identified that we need, that this counseling is not being routinely done. And that often then it's not either, we just looked at some data related to the lack of postpartum counseling in even at follow-up visits. And so this is really something that we're going to propose so that we hope it supports hospital systems and individual hospital facilities starting that transition of care by providing, reinforcing that information that, the goal would be to both educate the patient ahead of time so that it increases compliance, they attend more postpartum care, and they're more inclined to continue care beyond the immediate postpartum period. Next slide. So this is a checklist that's already available, but we know that optimal care at postpartum discharge for women with hypertensive disorders requires really multiple essential elements. Obviously, the education is a metric that was sort of a piece of this, but there is a lot that needs to go into the appropriate counseling and education of a patient who's suffered a hypertensive disorder before she leaves the hospital. So this includes education about warning signs, support for home blood pressure monitoring, arrangement of a problem-focused office visit, depending on timing based on the patient's needs, counseling on recurrence risk and subsequent pregnancies, even starting to talk about what it looks, what a future pregnancy would look like. So this is a really nice discharge tool that we are actually trying to integrate at my facility locally, because I think again, if you asked me what we were doing right now, we are only doing a very sparse number of these really critical elements in the patient's counseling prior to discharge. Next slide. Again, this is still sort of the same checklist. It's just the part that's focused on follow-up and ensuring that the patient has appropriate follow-up scheduled, as well as, particularly if she's going to use remote monitoring, ensuring that she has all the tools available to do that. And so I think this is a really nice, if you guys haven't seen this resource, really nice to consider implementing at the hospital level to help support appropriate discharge, counseling, and follow-up prior to discharge of patients who have suffered a hypertensive disorder. Next slide. And I don't know if you all have seen this. It is on one of the AIM bundles. I think maybe it's not as, kind of well known as some of the others, but and most AIM bundles are really oriented to the inpatient setting. Of course, this is an inpatient bundle, but it's really oriented towards getting the patient ready for the postpartum transition. And so it's a particularly relevant bundle as we're talking about optimizing the postpartum period and improving the transition to postpartum care. This actually, in our hypertension efforts in Texas, we actually implemented this, at least elements of this postpartum discharge transition, along with our hypertension when we made our driver diagram, because we really felt like a lot of this drove sort of the appropriate transition of care, as well as there's some important equity measures that are in here about trying to ensure that we've got the patient connected to their community and that they're able to follow up appropriately. Next slide. Finally, I wanted to share, and I actually should have put one more slide, but I'm going to share two things that we do locally, and you guys may already have things like this, but just sort of talking about what have we done to try to look at optimizing care for patients with, again, in this case, hypertension, but medical comorbidities before they are discharged from the hospital. And in this case, we really have a very firm guideline for patients that have elevated blood pressures from whatever their hypertensive disorder or pregnancy is, that we would like their goal to be, their blood pressures to be at less than 150 over 100 for 24 hours before hospital discharge. And we found that when we looked at our readmission data prior to implementing this change, we realized that we had patients that were coming back, which, again, that's not necessarily a bad thing. It means they're recognizing that they may have elevated pressures at home or symptoms. But we also realized that, hey, some of these patients were discharged inappropriately in the sense that they had elevated blood pressures before they even left the hospital. So in this case, we've really found that we have been able to reduce the number that come back by following this, so that if we make sure that their blood pressures are optimized, that they start or are titrated on on an oral antihypertensive med, that we wait at least 24 hours before they're discharged. And of course that we aim for the goals of, it says 3 to 5 days, but we've really moved to 3 days, probably, hopefully, like many of you have, but really making sure that we have an early blood pressure check scheduled for the patient. All right, next slide. All right, so we're going to talk just a little bit more about the kind of postpartum, that second transition into the real postpartum period and beyond. Next slide. So why is postpartum care critical to overall short and long-term wellness for women? So when we talked about, there have been a bunch of major themes that were identified when we talked about sort of the discussion here. So first of all, we know that 15% of severe maternal morbidity develops de novo within the first 6 weeks of delivery discharge. So that's really the emphasis on the short, right? Even women who didn't have risk factors are going to have a new complication that wasn't previously recognized. And if we don't get them in for care, we will, we lose an opportunity to intervene on their behalf. Less than half of women feel prepared to care for themselves postpartum. Greater than a third of women experience lasting health problems after birth. Poor maternal, physical, and psychological health in the postpartum period adversely affect the health of their children, and that pregnancy complications, of course, can portend an increased lifetime risk of cardiometabolic disease. Next slide. So in addition to increasing maternal mortality associated with pregnancy, the number of women dying because of cardiovascular disease has increased recently. So this increase in mortality has been attributed, in part at least, to the risk of death in younger women with cardiovascular disease due to lack of recognition and undertreatment of young women with cardiovascular disease. And we know that adverse pregnancy outcomes, or what's referred to as APOs often, which are risk factors for premature disease, affect approximately 30% of birthing people, which is a really large number. So this includes, of course, conditions like preeclampsia, preterm birth, for example, and they occur more frequently in Black women, who often present with more critical clinical presentations and poor outcomes. So identifying this group of women with a history of adverse pregnancy outcomes is also a unique opportunity to target women at increased risk for cardiovascular disease and initiate primary prevention efforts in this high-risk cohort. Next slide. So despite the relatively clear need to identify at-risk women in the postpartum period, we are really not currently capitalizing on this opportunity to identify, triage, and coordinate care for women who bear increased risks. So this is from a study about 10 years ago, but it wasn't that long ago. And it looked at primary and postpartum obstetric care utilization in the US for the 12 months after delivery. And it compared complicated pregnancies to a comparison group. They stratified their findings by insurance status. And basically what they saw was that 65% of medically complicated women with Medicaid attended a postpartum visit, which was actually higher than the attendance rate for complex but commercially insured women. Primary care visit attendance within 1 year was similar in the two groups, with 50 to 60% attending a visit, and a little bit higher if the woman had diabetes or hypertensive disorder. So really, even though, of course, we don't expect the rates are probably ever going to reach 100%, this is pretty dismal for a group of women, many of them who we already know to be at risk, and we have an opportunity to do better for them. So we hopefully will start doing, you all and all of us together will be part of a change in these trends. Next slide. So there's many reasons why women may not attend postpartum or transitional care appointments. I'm not going to go through this at length, but I'm sure you know this. And this is, again, kind of partly hearkening back to how to, we need to really consider all these factors as we're talking about how to optimize care. So it can be coverage challenges, lack of provider, continuity, transportation, childcare hurdles. So there's a number of structural, individual barriers, as well as experience of care that really can deter women from getting the appropriate care that they need. Next slide. So if we're talking about goals, again, we want to reduce maternal morbidity and mortality. That's number one. But we also not just want to reduce that. We want to really optimize. We want to go from, we want to reduce death. That's a pretty low bar. But we also want to make these women's lives, both in the short and long term, better. Improve access to care, improve the quality of care. And of course, we want to reduce racial, ethnic, and payer status disparities. Next slide. So it's really going to, it's really going to require a shift in the paradigm of how we take care of patients in the postpartum period. This recommendation for a shift from the traditional 6 weeks to a much more sort of ongoing period of contact with the patient to assess needs and have early contact with her is something that's really been touted by ACOG since 2018. But I'll say that I certainly, in my personal experience in my own facility, it's something that's been hard for insurance reasons, for capacity reasons, to really operationalize, but it's really important that we keep pushing on these needs, because honestly, it's going to be hard for us to make all the changes that we need to if we aren't able to have more regular contact and assessment of these patients. Next slide. All right, so to really make these transitions seamless, again, we focused on what we need for that first transition of care, but there's really many steps along the way to ensure that the patient, receives both optimal postpartum care and then also is able to transition to ongoing care. And these include things like access to records, quality tools to ensure that we, offer patients high quality visits, and that we are supporting available evidence, that we are giving them ideally availability and support for lactation, social, and care coordination needs, that we're able to refer them and communicate with our referring providers. So again, that's not an exhaustive list, but there really are a lot of elements to improving the postpartum and long-term care needs as well. And so I think we just need to be kind of cognizant of all these various things, because fixing one of these without sort of, really accounting for the rest aren't going to have the same amount of success as if we can really take these all together. And again, hence why I think the AIM bundles are really a superior way to do this in the inpatient setting, but we really need to translate that to an outpatient setting as well. Next slide. In terms of addressing access and structural barriers, so talking about clinical care. So how do we improve clinical care? Because we talked about we can have all the research, we can know what we need to do, but that we aren't able to actually operationalize that for various reasons. Again, there's a lot of barriers for patients. So these are some of the innovative delivery models, care delivery models that have been tried that I'm going to share with you. And again, I'll try to fly through these because I know we're running short on time, but I just want to make sure that you're aware of what's being tried and what's, again, been successful to date. Next slide. So text messaging, I imagine that many of you have heard of it, and maybe in some of your health systems you're using it, but it's definitely a low-cost way to improve patient communication and foster behavior change. So this study highlighted on the left is out of UPenn. It compared text-based home blood pressure monitoring with standard office-based blood pressure surveillance in the first 7 to 10 days postpartum, and they found that over 90% of women recorded a blood pressure within 10 days with the use of the text platform versus only about 45% in the standard screening group. So other benefits to texting: improved medication compliance, increased postpartum visit attendance, engagement, improved patient education, etc. So this is a really nice, innovative platform that I hope and believe will be used more widely with time, that can really improve some of the barriers that prevent patients from getting adequate care in the postpartum period. Next slide. So patient navigation is another innovative care delivery model being explored with promising results. And some of this I'll say, I know that I've seen in Texas, some people are doing this, although maybe the more logical place is at the ambulatory or is in the ambulatory space. I know there are places that are realizing there can be big deficits in this first transition of care, are trying to get patient navigation services available in the inpatient setting that sort of help as patients are moving into the outpatient environment. So patient navigation is it's a longitudinal patient-centered intervention that offers support to an individual patient for a defined set of health services. And this has been shown to increase postpartum visit attendance, increase contraceptive uptake, increase completion of postpartum glucose screening, and improve depression screening. So navigators, they don't necessarily have to be, they can be healthcare workers, but they can also be trained lay people. And so there's a huge number of benefits, and this really opens up the pool of people that can offer this sort of patient enhancement. And I think this is going to be important, again, going forward. It's certainly something we are also, I think paying for this can be tricky, but it's something we're exploring, I know at my institution, and has had great success thus far. Next slide. There's also combined approaches that use both patient navigation and texting. So again, allowing particularly a non-healthcare professional that may not be quite as strapped for time, which can be, I know, a huge constraint for the rest of us, but that maybe this is what they do. It really can allow them to engage with the patient, particularly potentially in a virtual platform where they don't have to see them, but really allows for that level of engagement and extra education. Next slide. Electronic reminders, I think these are interesting because it's really a provider-focused solution. So this is something that, again, can be, it's an automatic reminder in the EHR that tells clinicians, hey, this patient had a certain diagnosis. Make sure that you talk to her about transitioning to primary care cardiology, documenting her cardiovascular risk factors, making sure that she's counseled, and then, you know, advising her to seek preventative care within a small time frame. So again, you can see that the use of this, they called it a nudge, did result in improvements in these transitions of care and counseling from usual care. Next slide. And then I just want to highlight that there are these complex care transition clinics. This is from data, a long-term study looking at one of these, you know, specialized clinics where they were really focused on women coming out of the postpartum period with multiple risk factors and seeing if they could comply with a set of health, you know, recommended monitoring strategies. And what they showed, of course, was that there was, although not all of them, but certainly that they had higher rates and even honestly higher over time of compliance with these different, you know, healthcare assessment measurements that they were recommending. So I think, again, I'm going to show you sort of our low cost solution on the next slide. If you want to advance for me, Amy. So this is from our postpartum, we call it our complex postpartum care clinic. I only mention this because this was really, obviously many of us don't have a 5-year, you know, funding for a 5-year plan or a clinic dedicated to postpartum care, but this was really like kind of a a relatively low cost solution. So we basically, one of our MFMs is interested in this. We identify women with additional risks that really would benefit from additional counseling, because I know that can be a strain for our general OB-GYNs who have 10-minute or 15-minute slots, but they really don't have time to do this counseling. So we schedule a counseling visit. We talk about the patient's risk factors and her risk of premature cardiovascular disease. And we offer a cardiology referral to the patient. And if so, then we obtain labs and they follow up with one of our cardiologists who's interested in cardio OB. So this is really like, we do this a lot on telehealth. This is not super, sophisticated, and it didn't require a lot of, it's paid for by the patient's insurance. So again, it's just one solution that may be an option to help patients, sort of transition and streamline their care over time. Next slide. So for the last few minutes, I just wanted to show you, and again, you may be aware of these, maybe not. I just wanted to make sure you know these resources are out there, but really talking about how we support and measure postpartum care quality improvement. So the available toolkits, bundles, checklists, and metrics, again, some of which you may have seen before, but I'm hoping maybe a couple of which you haven't, and that you'll look at, for possible use in your particular health system or hospital going forward. Next slide. So the Fourth Trimester Project is a toolkit developed to improve postpartum care and has resources for both patients and providers. So it's really nice. It includes both educational materials, checklists, informational videos, and other quality-related products meant to enhance postpartum care delivery. So it's really got a ton of resources there. And so if you haven't seen it before, it is something that can be integrated in either an inpatient or an outpatient setting. So wanted to draw your attention to that available resource. Next slide. This was a tool checklist that we developed when I was on the SMFN Patient Safety and Quality Committee, because we realized that ACOGs, there's a lot that's supposed to happen at these postpartum visits, and although ACOG had some guidance, it was honestly very hard. There was no real visual aid or support available for trying to remember all the various components that were important. So we split this out into two actual checklists. One is just a standard for all patients postpartum visit checklist, and it's the 5 Bs of postpartum care, which is the way that this is addressed in and taught in in medical school, but just sort of a way for clinicians to prioritize and ensure that they ask about all these really critical elements, because there really are a lot of things to cover in usually a relatively short amount of time. Next slide. The second checklist is really for complex patients who have suffered either a pregnancy complication or they have an underlying medical condition. And it talks about what's really needed for this patient. Do they need follow-up? Do they need referral? Do they need additional counseling? And it's preconception counseling recommended before they move on to their next pregnancy. And so I think this is helpful, again, particularly for general OB-GYNs or even midwives or other, care providers can use this list if you're not super comfortable taking care of these patients and you're not sure what they need. This is a great visual aid and cognitive resource that can be super helpful. So again, if it applies or be useful for you, then please check it out on the SMFM website. Next slide. I think many of you probably have incorporated this. This is certainly something we've been focusing on the inpatient side, but obviously translates into the outpatient setting. But this SMFM measure, I thought it was helpful. It came out to really codify timely follow-up of severe hypertension. ACOG had said 3 to 5 days, but really this really sets the standard for that 72-hour follow-up, and it gives, sort of very specific measure definitions. So this can really be tracked based on billing codes from claims data. And so it's a way for us to see what's happening in the follow-up realm. And we know that this is a significant gap that has been a major challenge. And so again, this is just, if you haven't seen this before, it's something that we use to help sort of cajole and recommend to our inpatient teams that they implement and follow. Because I think it's something that we hope will take better hold and that will start being tracked potentially by others, and insurers would be great, facility level, etc. So I just want, again, if you haven't seen it, please check it out. It's a great measure that we are using and really implementing strongly in our hypertensive efforts. Next slide. And then finally, I told you that we really split out the first when we were looking at where we need to sort of create quality metrics to better measure some of the postpartum care. We kind of came up with this two-pronged measure. This is the second part of it, which is this timely transition to postpartum care. So it's the percentage of patients with a hypertensive disorder of pregnancy who have an office visit with a primary care provider within 12 months. And so I think this is a really, again, interesting addition to the measure landscape, because we haven't had a way, people had not had a way of measuring this. It hadn't really been on the radar, but this is such an important and critical part of long-term care for patients, particularly those who have had some sort of complication during their pregnancy. Next slide. So finally, basically, this is just sort of to summarize the important points. We know that intrapartum and hospital-based morbidity and mortality have declined, but rates really remain unacceptably high both before and after delivery. There's no healthcare quality without equity, so equity considerations are really fundamental. I know we didn't focus on that much, but I wanted to make sure that we were very clear that that really is a part of much of what we're doing, and we hope by implementing these strategies that we will help bring part of the increase in respectful care and equitable care for our patients. Improving postpartum care follow-up and long-term health starts before the patient is discharged. That should say before her delivery hospitalization. So making sure that we're really focusing on that critical period and what we can offer, even if we're really confined to the inpatient setting. Despite long-term health implications of adverse pregnancy outcomes, postpartum care, transition to primary care is really inadequate and inequitable. And so we really need to shift and include that transition to a patient-centered alternative care model and implement these quality tools that are all available. And again, I hope that you guys will check them out if you haven't seen them already. I'm sorry that went so far over. I knew I had too many slides. Any other questions? Oh, that's very sweet. I wish I could move. I don't really love Texas, but my family lives here, so I'm kind of stuck.
Thank you so much, Dr. Morgan.
Well, I really appreciate the opportunity and thank you for your attention. If you guys have any questions for me, I should have included my email. Obviously, if you have any, please pass them through. If there's anything I can ever do for you, just Amy has my email and I would love to answer any questions or have any additional discussions. So thank you all so much for your time and attention. I appreciate it.
Thank you all so very much. And just a reminder to complete the biannual survey, and a reminder that the slides and the webinar will be placed on our website, and I will send out when that recording is ready with you all with some of these tools as we add those to our our resources on our website as well. So again, thank you, Dr. Morgan. Wonderful presentation. Hopefully our teams can use some of these resources and tools moving forward in the work that we're doing. So you guys have a great day.
Thank you so much, guys.